Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
Hello, everyone. My name is Catherine. I am the intern at Blum Patient Center.
Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it will be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Catherine, who will introduce you all to today's guest speaker.
Joining us today is Dr. Giovanna Manzano. Dr. Manzano is a multiple sclerosis specialist, neuroimmunologist, and neurohospitalist who sees patients at Mass General Hospital and Brigham and Women's Hospital. She is the Director of Quality Improvement of the MGH Neurology Department, Division of Neuroimmunologic and Neuroinfectious Diseases, and is also teaching faculty for the Mass General Brigham Neurology residents and Harvard Medical School students during their neurology clerkship at Brigham and Women's Hospital. Dr. Manzano's clinical and research interest focuses on clinical trial design and patient-reported outcome measures for patients with multiple sclerosis, autoimmune encephalitis, neurorheumatologic conditions, and immune therapy-mediated neurotoxicities. She joined us today to give a talk on multiple sclerosis as we age. Please join us in welcoming Dr. Manzanos.
Thank you, Catherine, for the kind introduction. I'm going to share my slides here. Okay, let me just put it in full. Okay, so thank you to everybody who's joining today. And as you heard, please do ask questions in the chat and we will go through them at the end of the talk today. There will be plenty of time to answer your questions, so feel free to ask whatever might be on your mind related to this topic. So today I hope to be able to provide you with an overview of what multiple sclerosis is, but more importantly, really dive into how does multiple sclerosis change as we grow older, and then how does your treatment plan change in that context as well, sharing novel research developments that we're learning about MS as we age, differences in approach to treatment selection, as well as just an overall what to expect from a patient perspective. So let's get started. So here again is an outline that I just shared with you, and really we're going to spend the majority of our time thinking about MS as we age, but I think it's so important just to be sure before we get into the intricacies and all the nuances of that topic that we really just take a moment to better understand multiple sclerosis as a condition here. So what is multiple sclerosis? So multiple sclerosis is essentially, predominantly, I will say, an autoimmune attack on parts of the nervous system where there is a protein called myelin. Myelin is very important. It sheaths our nerves, so it allows appropriate signal transmission. And by way of doing so, we are able to use our muscles with full force. We are able to feel kind of the sensation of the world around us, and we're able to see things very clearly because the brain, the spinal cord, and the optic nerve are all the many locations where myelin is very important for the function of these parts of our nervous system. Although these are the most common presentations of multiple sclerosis, there are certainly other ways that the nervous system is affected, namely something called the autonomic nervous system. We'll touch upon that a bit when we talk about symptoms and chronic management of symptoms related to MS, but really think about MS as a way of conceptualizing the immune's attack on the brain, the cord, and the optic nerve. And I started by saying, it's predominantly an autoimmune condition because actually there's a second piece of what multiple sclerosis is that truly has only recently in the past decade or so gained notable attention to really understanding the significance of this second part of what makes multiple sclerosis the condition that it is. And what that is the second bullet point that you see here, neurodegeneration. And I have in parentheses by it a word atrophy, right? Atrophy essentially means shrinkage of volume. And that's a scary word to even think about, so we're going to go into what that means and trying to conceptualize how do we prevent something like atrophy from happening to our patients with multiple sclerosis. There are variable ways in which these components of the condition affect someone, right? So for some, there's a predominant autoimmune attack that's going on. And for others, it is actually more predominantly the neurodegeneration piece of MS. And what differentiates that to us on our diagnostic studies is when we look at an MRI, is what we're seeing these white matter hyperintensities. So if you read an MRI report, let's say if you have multiple sclerosis, the radiologist is going to write something to the effect of T2 flare hyperintensities or white matter signal change or white matter lesions. These all represent the same phenomenon of what's happening at an immune level of the immune system taking away pieces of myelin. When it does that, we see these white marks on our MRIs, which are essentially multiple scars. So when I try to best understand, what does multiple sclerosis even really mean at the root of it, it means multiple scars. So your immune system has left behind areas of damage. Our job as providers is to protect you so that way we can minimize the number of scars you get from this condition. And that's a really important piece of the puzzle that we're going to spend a lot of time speaking about today, is this proactive course of action to really help you age with multiple sclerosis as gracefully as we want to. Being proactive and not reactive is really critical in this condition. So who does multiple sclerosis affect? Well, there is a predominance for the female sex, and that is something that's common amongst many autoimmune diseases. There's a lot of research looking at how hormones might play into that, as well as some degree of epigenetics. But it's not as simple as sex alone. As you can see, a pretty decent proportion of men also have multiple sclerosis. What you might notice here is that the numbers are a bit small on the slide, but if you break it down just looking at the United States alone, there's a bit more by way of cases of MS in the northern northeast hemisphere of MS, and that really plays into the epidemiology of multiple sclerosis. So risk factors that we know can increase the likelihood of someone developing MS and even having a more active disease course are related to geographic locations. So there's actually an increased prevalence in the northern hemisphere. And a way that we can best understand this to some degree is there is certainly an associated risk with vitamin D deficiency. And as many of you know, if you're locally to this area, the winter time, we are definitely not getting natural vitamin D. So we need to really work on this proactively here, because this is an identified risk factor, not only for disease development, but also disease activity and chronic, what we call smoldering inflammation, that really plays into this more neurodegenerative piece of what makes multiple sclerosis what it is. In addition to location, vitamin D, smoking is a big risk factor for MS. So cigarette smoking, whether that be primary inhalation by the person with multiple sclerosis or secondhand exposure, both are dangerous. Both can increase inflammation and worsen your risk of relapse and active disease. So these are things that we can modify. And lastly, many of you may have heard about a recent study now within the past 2 years that came out of the Veterans Affairs hospital system, the VA system. And what they looked at were military personnel before and after MS diagnosis. And what they found in their cohort was that patients who went on to develop multiple sclerosis had evidence of EBV exposure. EBV is Epstein-Barr virus. This is of the herpes class of viruses that actually causes common cold. For some, it causes mononucleosis. And so it's a virus that's very prevalent just in our day-to-day society, but does also seem to have an association with MS. But again, it's not this simple. It's definitely a combination of all these environmental factors and some genetic risk. And maybe there are other factors that we just haven't even found quite yet, because even with someone who's the most optimally vitamin D replete, doesn't smoke, hasn't had a known EBV infection, lives in the southern hemisphere, you can still develop multiple sclerosis. So there are pieces of the puzzle that we're still missing. So we're certainly not in a place from like a research treatment perspective to prevent disease onset from an exact T, but we know that there are things we can do to help reduce the likelihood of developing MS. And also should be said that age, really most commonly multiple sclerosis will come on in a young adult. So typically it's someone in their 20s to 40s, but there is pediatric onset multiple sclerosis, very young ages, as well as what's called late onset multiple sclerosis. And we think about patients who are having their first attack of MS in their 60s, even their 70s or later. So the spectrum of who this disease affects is pretty broad. And with that is broad heterogeneous clinical symptoms as well. And so we're going to talk a little bit more about, what makes someone symptomatic from multiple sclerosis and what this looks like. Now, somebody who sees patients for new diagnoses or concern for diagnosis of multiple sclerosis, I can definitely understand the confusion that might come about if somebody has one of or many of the symptoms listed on this slide here, but then leaves the clinic visit with learned information that they do not have multiple sclerosis. So why is that? The diagnosis we'll touch upon a bit in a few slides ahead, but it's a bit complex. So as you can imagine, a lot of these symptoms here could be caused by multiple things: changes in vision, weakness, numbness. There's so many neurologic conditions alone that you can think of. Stroke, you could think of neuropathy, you can think of a primary eye issue. There are many different things that can present with these symptoms. So although one person might have these symptoms, it's so important to, of course, voice the experience of these to your primary care provider, who then will help inform the context that these are developing in and get you to see a specialist, to further either affirm or refute the diagnosis of multiple sclerosis. Again, we touched upon this at the beginning, but at least the top 6 symptoms can be directly related to, a spot where myelin was affected. So your vision, you think about the optic nerve most commonly, although there are pathways in the brain tissue itself where vision could be affected if there was an attack. Strength and numbness can be from the brain or the spinal cord. Coordination most commonly could be directly from a part of the brain called the cerebellum, and so could balance. But of course, if you have your numb sensation abnormal, that's going to be hard for you to know where you are in space. And so this plays into why there might be multiple lesions that are actually giving someone a particular symptom, inclusive of bowel and bladder dysfunction, which typically reflects an autonomic nervous system involvement of MS, which is a bit less commonly talked about, although there are pathways in the brain tissue itself that could also lead to these bowel and bladder dysfunction, as well as along the spinal tract. So there are a myriad of treatments because multiple sclerosis can really affect wherever it likes in the pathway. So our job is to make sure that doesn't happen. Now, these final 3 bullet points that you see on the screen are really going to be the forefront of what we talk about when we think about MS as we age. So I have memory and cognition up here. And the reason being is you might remember that I've spoken about MS as an autoimmune condition, but also there's a secondary neurodegenerative component. So let's say we have a diagnosis of multiple sclerosis in our 20s and we go on to live many decades and not be treated with anything to really slow the inflammation. Everyone has very different journeys of multiple sclerosis, what this disease is to them, how it affects them. But the more common outcome in that type of scenario is, if untreated, we might see atrophy and weakening of the brain tissue that is called the gray matter. And it's these, what we term gray matter symptoms, the memory changes, the mood changes, the cognitive changes that are more apparent as we age in MS. Certainly these things can happen earlier in the course of disease, but this tends to be more reflective of that secondary neurodegenerative piece of the disease and less so of this acute inflammatory attack of MS. So just further fueling, the rationale for why MS specialists will very strongly encourage treatment start. And lastly, spasticity and pain. These symptoms can come early with an early attack, but typically are more chronic symptoms that need to be managed with time that are resultant from things that happened in the past. So these conditions, these symptoms that are caused by MS attacks may have variable attention needs at different timelines along your journey of MS, but it's really these final three that we think about most, as we age. And the initial tend to be more acute, but certainly can be present as we continue to age as well. So you've heard me touch upon the fact that the diagnosis of multiple sclerosis is not directly straightforward, right? You could even have every symptom on that last slide that I shared, but not necessarily have these symptoms because of multiple sclerosis. So I'll share briefly about what a neurologist will think about when we think about giving the diagnosis of MS. So the history of these symptoms are certainly important. They're going to drive where we focus our physical exams. They're going to drive where we focus what type of MRIs to obtain, as well as what other conditions do we need to rule out as being causative for these symptoms. And so with that, if you meet a neurologist who's evaluating a diagnosis of MS, you're going to undergo a very thorough neurologic exam where we'll test different components of your strength, of your sensation, of your balance, of your eyesight. We look at your reflexes. We think about what blood tests to order. There are some mimics that are infectious, that are metabolic, meaning things like certain vitamin deficiencies can make white matter changes on MRI that are actually from these metabolic sources. We think about other autoimmune conditions. So there are two other demyelinating conditions that are similar to multiple sclerosis in some ways, yet very different in others, that we need to really exclude because the treatment will be different based on which of these three demyelinating conditions you might ultimately have. And of course, imaging, you've heard me mention already numerous times, is certainly going to be a part of the package of a diagnostic evaluation to really gather all the data we need to know if what you're experiencing is from multiple sclerosis. Lastly, I have down here cerebral spinal fluid testing. Cerebral spinal fluid is what bathes our brain, bathes our spinal cord. We gather that through a procedure called a lumbar puncture. It's something that's done very commonly in our clinics. So although sounds quite invasive, is something actually very routinely done, where we sample the spinal fluid. And the reason is if there is a history that's concerning, but we're just quite not making the full diagnosis with the data that we gather from imaging and history and exam, sometimes you might need a lumbar puncture to get the spinal fluid to show that you have certain inflammatory markers that are used when we make an MS condition. So not everyone needs a lumbar puncture because in some situations you can already have a sufficient number of clinical symptoms and events and the appropriate MRI findings to say, this is it, we have multiple sclerosis, but there are some cases that perhaps we're catching a bit early in the course or are just atypical where you do need to gather the spinal fluid as well to fully make the diagnosis. So this slide on here is actually now outdated by a month because the revised McDonald criteria, which are diagnostic criteria that were shared with the MS community, are now officially the 2024 McDonald criteria. There's not so much a beautiful schematic like this available that I can find quite yet. So I leave this 2017 up here because I feel like it's very neatly organized and just lets us use as a talking point. And I'll share, what was added in 2024. But essentially what you might notice if you really spend time to look at this here is the way that a provider is thinking about do you meet criteria for MS or not is based on two principles. It's called dissemination in time and dissemination in space. And what this essentially means is, did you have two attacks in time or some objective data that shows us that maybe you had one clinical attack, but there's evidence of prior inflammation on your spinal fluid, let's say. Did you have dissemination in space? Maybe you had a attack of weakness of an arm for your first event, but your brain MRI shows us that there are other areas in the brain that have been affected by multiple sclerosis. So this again is why if we think back to that last slide, there are so many different pieces to the puzzle that have to be gathered because everyone's point in which they present to a neurologist is going to vary. Maybe you've only had one attack at that point. So what other diagnostic information is needed to really let someone feel certain that this is multiple sclerosis so we can move ahead with the appropriate treatment plan? And on here, you'll even notice that we have criteria for different types of multiple sclerosis, which I'm going to spend some time talking about in a later slide. So what was added in 2024? Really, the most important things to take home from that were that optic neuritis, which is inflammation of the optic nerve, which can cause vision changes such as Sometimes it's as subtle as a blurriness of vision, sometimes described as like a smudge on a windshield type. Other situations of optic neuritis can be very severe, where you can completely be unable to see things such as even light out of an eye that's affected. Sometimes both eyes are affected. Because optic neuritis is something that has so many different potential underlying conditions that can cause this, in the past, it was not felt to be appropriate to be on the McDonald criteria. The network of MS providers, the majority of them have decided that, in doing that, we might be missing early diagnoses of multiple sclerosis. And you've already heard me say that really what we can do is be proactive for this condition. So we don't want to miss any early diagnoses. We don't want to say, well, your first attack was optic neuritis, that doesn't count, right? Because we might then miss the ability to prevent a second attack somewhere else. And so on this new criteria, we actually will permit one of the clinical attacks to meet justification in time and space to be optic neuritis. And as we're getting better at our MRI technology and modalities, there are now more specific imaging features that are included that doctors can really take into account when you look at an MRI to say, this is enough evidence to say this is multiple sclerosis. I can move forward now with a plan of care, which is what we want. We want to be proactive. We want to get ahead of this so that way we can age without much accrued disability. So I think it's very important before we really jump into multiple sclerosis through time and thinking about that everyone might start their point in treatment at a different phase of multiple sclerosis. We also term this as course, the different disease course of MS. But I think phase might make a bit more sense to some. So CIS stands for clinically isolated syndrome. What this is thought to be is essentially the first clinical attack of MS, but not fully meeting those dissemination and time and space criteria to really make diagnostic criteria for multiple sclerosis. As our field has become to acknowledge the importance of early treatment, so has the recognition that clinically isolated syndrome is equally as important to start treating as is multiple sclerosis that meets the full McDonald criteria. So there have actually been numerous clinical trials and retrospective studies and data to support treating patients who present with clinically isolated syndrome, meaning they've only had one attack, but we want to keep it that way. And we've excluded all other possible mimics. So we feel comfortable starting the multiple sclerosis for MS because we're committing to the idea that this is the first attack of something that is going to come if we just sit back and not treat. What helps doctors want to further treat clinically isolated syndrome, there are certain findings on MRI that might be suggestive of multiple sclerosis, even if they don't fully meet diagnostic criteria. Lumbar puncture might be pursued because if we see something called oligoclonal bands, which is evidence of past inflammation, that then would provide further comfort that this was something inflammatory, that although you had one clinical syndrome that led you to present to care, there's actually evidence that this inflammatory process has been around more. But really, most importantly, is excluding anything potentially else that could be confounding the situation. But again, important to treat and treat early. So then we think about the most common course of multiple sclerosis, and that's the RRMS, or relapsing remitting MS. Relapsing remitting multiple sclerosis is the most common, and it is, as it sounds, to a certain degree. Everyone is a bit variable in what truly a relapse will result in, and what does that remission period really mean. It never quite fully means full clinical remission, and I have a figure of an iceberg here on the slide to really demonstrate the concept I'm going to share with you now. If you have a relapse and you have an attack, that might leave you with a residual symptom. It might not. You actually might return completely being asymptomatic. But even without a symptom that's experienced on a day-to-day basis, we actually know that there has been some neurologic injury to somewhere along the brain, the spinal cord, the optic nerve, depending on where this inflammatory attack occurred. So this would be the part of the iceberg that's under the surface, right? You might not be experiencing that full insult to its full effect, but it's there. So we know that patients with relapsing remitting MS, although many might feel fine after a relapse and their symptoms completely go away, there are some damage, some change under the surface that has occurred, which is rationale for why we need to treat. We can't rely on the hope that after a relapse, you're always going to fully remit to be asymptomatic, because even without a symptom, there is some damage that has happened. There are many situations where that's not the case, even where someone has a relapse and they're left with something. It might not be as significant as the first attack was, but there's still some residual weakness, some residual balance change, some residual numbness. And these types of residual symptoms are often exacerbated, or we use the term sometimes flared, in settings where your water level is lower. What I mean by that are things like urinary tract infections, not sleeping well, even mental, emotional fatigue and stress can lower your water level in such a way where the insult under the water usually actually rises to the surface. And so a good example of that might be someone with multiple sclerosis who had an attack that caused right arm numbness in the past, seem to mostly resolve where now they only have fingertip numbness on a day-to-day basis. But feeling very ill, have the flu, don't feel great. And in that setting, the right arm feels numb and tingly just as it did the first time. So important to let your MS provider know if that's happening to you. Oftentimes, if it's a symptom of something that's happened before, we will obtain MRIs, but actually not see any evidence of active inflammation. And this brings us back to this iceberg concept. It's not that your multiple sclerosis is now active in the setting of you being ill with the flu. It's this principle of what we refer to as recrudescence. It's a reemergence of a symptom that's usually buried under the surface that's now reappearing. And so it's important to recognize that's a possibility, but more important to let your doctor know about that, because it's important with every time you have a new symptom to evaluate it, to be sure that what's happening is just this reemergence because of some factor like being ill or fatigued or stressed, and not a new lesion. Because having a new lesion is very important. We live in an area where we have so much at our disposal now for the treatment of multiple sclerosis, whereas 10, 20 years ago, we were very limited with what treatment options we have. Now, because we have such great treatments, we have options to say, well, you've had another attack on drug X, let's try drug Y, right? There are other things we can do because we want to be so proactive to make sure that you're not in a situation where you even get another white matter spot on your MRI or new symptoms. We have medications that have such great probability of keeping you from having relapses that we want the best to be sure that you don't continue to have these attacks or these marks. And that's so important because really all relapsing remitting multiple sclerosis is by definition also with time going to become what's called secondary progressive multiple sclerosis. So even someone that has relapsing remitting from the onset, we always are, as doctors, are worried about making sure we're on the right, most effective medication up front, because we know as we age, there is this chronic smoldering inflammation that's going on in the background. And we want to stop that chronic inflammation. We want to stop the neurodegenerative changes that can come if we're not appropriately aggressive with treating multiple sclerosis when we have it then and now. And so for that, we really think about so many different treatment options that we individualize for a patient based on who you are, what's your childbearing potential or future plans look like, what comorbidities do you have? Do you have blood pressure management needs? Do you have other cardiac conditions? Do you have diabetes? Have you had issues with your vision for primary ophthalmology causes? There are so many different factors that we need to learn about a patient to really put them on the most optimal MS disease modifying therapy, referred to often as a DMT. So we really need to learn a lot more about you to best treat you, to be sure that we can prevent any progression that we potentially can. In some cases, multiple sclerosis may start off as progressive, and that's what's the primary progressive MS, the last column that you see here. This type of multiple sclerosis, it doesn't have so much of the relapses and the remissions. Rather, there is this chronic progression that's gradual through time. But if I see a patient at the beginning, I see them in 5 years, I might notice a change in their walking speed, a change in their dexterity. And it might not be something that you wake up and you say, oh, wow, it's harder for me to do this today. It's something that's noticed more over, again, a period of time. And there's so much more about this phenotype of multiple sclerosis that we have yet to understand. But in the past few years, we reassuringly have developed a drug called ocrelizumab, And this medication has been approved for use in primary progressive multiple sclerosis. So that instead of meeting someone and providing this diagnosis and saying, well, we don't really have great treatment options, we actually do. We have something to try. And it might not be as effective as it is for relapsing or remitting multiple sclerosis, but it certainly will help slow inflammation to a degree. And so again, very important, even if you receive a diagnosis of primary progressive multiple sclerosis, to talk to your provider about what treatment options there are for you, because we do have the luxury of having so many medications now, some of them having shown efficacy in slowing progressive types of multiple sclerosis as well. Before we kind of continue on in the treatment management perspective, I'll just pause a moment here to mention radiographic isolated syndrome, because often this does come up. So you've heard about the more clinical syndromes. On MRI, sometimes we stumble upon findings that are unattended. So this type of case is often someone who has migraine, who undergoes an MRI of their brain, and now they're found to have these white matter changes that look like multiple sclerosis, but they've never yet had a symptom that would ever bring any concern for something neurologic to have happened to them. There are studies looking at the use of treatment of patients with radiographic isolated syndrome. What's so important is there are so many different causes of white matter changes on a brain MRI that it's very important to meet an MS specialist to be sure that what's reported from the radiology report actually matches with this diagnosis before thinking that this is the final diagnosis. So some examples of things that can give you white matter spots in the brain that are not multiple sclerosis are things like sleep apnea, high blood pressure, obesity, diabetes, migraine, prior head concussions. The laundry list is pretty extensive. And I want to share that because I want to also provide reassurance that there are many reasons why you might have an MRI report that says there's white matter spots there. So again, so important to contextualize it and to be sure with a specialist that this makes sense in your context, that these MRI features are sufficient to really meet this type of labeling. And if so, to then have a really informed discussion about what's out there in terms of the risks and benefits of starting treatment even before you have an attack. So there's one drug, dimethyl fumarate, that's been studied well, and it was shown to delay perhaps the onset of clinical multiple sclerosis in people that were appropriately diagnosed with radiographic isolated syndrome. So a pretty novel idea, as you can see here. This was published just in 2023. So certainly there's more to come in this world of research to better understand how can we be sure that someone has RIS most definitively, so that way we don't expose to side effects and immunosuppression unnecessarily. So here is now an outdated picture of drugs for multiple sclerosis, which is good. There are very common agents missing on here. There are two that are missing really. Ofatumumab, which is a self-injection once a month CD20, and then siponimod, which is something that directs itself against a peptide called an S1P. Siponimod is a future generation of fingolimod that you see already on here. Ofatumumab works very similarly to ocrelizumab. It's just a different administrative route. So I felt that this image is still sufficient. It just does a great job showing how far we've come from the early 90s, where we really just had what was referred to then as the ABCs of treatment. The ABCs stood for the brand names of the drugs that were available. And those drugs are really low efficacy. So we do much better now with these more modern drugs. Multiple sclerosis drugs work to suppress the immune system. And this is important to really spend some time thinking about, because we want to lower how strong a patient's immune system is. So that way we can reduce attacks, reduce progression, reduce that potential for neurodegeneration, while at the same time balancing the risk of immunosuppression. So for someone, a drug like ocrelizumab might not be tolerated if they already are someone with a very weak immune system who's had significant hospitalizations for infections throughout the year. You might not be able to use that high efficacy treatment in those situations. But if there's no significant contraindication to using a high efficacy MS medication, There was a treatment trial that showed that starting early with a stronger drug, these high efficacy drugs, will equal better outcomes down the road. So really, there's a huge push to use the best that we have available now to protect your future as we continue to age and get older. So I'll just kind of brief through this slide here so we can spend the rest of our time going over MS as we age. But it's important to, again, just to be mindful of the many different ways that MS can affect somebody, oftentimes with really what we say focal symptoms, like a new numbness, a new weakness, a new vision change. But these other things that you see up on here, the cognitive, the mood, fatigue, um, chronic consequence from these old initial attacks of pain related to the neuropathy or issues with urinary urgency or incontinence are important things that will oftentimes last much beyond the initial attack. So these are symptoms that at each visit after you're started on the MS medication, so important to kind of think about this at home before you go in, as well as with your provider, really go through each of these buckets and say, am I struggling with any of these symptoms? And if so, how can we make this better? Because we have so many different treatment options to treat each of these symptoms. Oftentimes we like to start with lifestyle modifications. I always really am sure to go over with my patients, how are they sleeping? How are they eating? How are they exercising? These things are critical for your neurologic well-being, your brain health, and are much better from like a longitudinal perspective at really managing a lot of these symptoms. But if you're optimizing these day-to-day lifestyle factors to the best of your ability and you're still struggling, we have medication prescription options to help manage these symptoms, as well as other colleagues in other disciplines like physical therapy, cognitive therapists, neuropsychologists. We have so many people on our team that we can help optimize a patient. So we certainly want to hear about a symptom you're struggling with. So that way we can make living with multiple sclerosis something that feels like a diagnosis that you are aware of, but not something that is impacting your day-to-day on such significant levels. We really want to try to optimize your functionality to the best of our ability. And we have a lot of tools that you can see here as a means to do so. So this I'll just skip over because we've already talked a bit about the iceberg model, but the one lasting point I'll add as a segue into the idea of multiple sclerosis as we age is that age time is also a factor that can lower our water level, which is why, again, it's so important to treat multiple sclerosis early because we know that as we age, that water level is going to recede. Things that are below the surface are going to be more impactful to our day-to-day, more symptomatic. So what can we do to make the bottom of the iceberg as slim as possible? And that's what we're going to spend the rest of the time speaking of. So we really need to try to tackle this chronic inflammation. And fortunately, as our MRIs have gotten better, we have better techniques for being able to visualize what are called slowly expanding lesions and other chronic active lesions. So what this looks like typically on an advanced MRI, such as a 7 Tesla, you might see some areas of inflammation that you actually would miss on a less powerful MRI, like a 1.5 or a 3 Tesla magnet. And with these advanced techniques, we're able to say, clinically, you're doing great, but your imaging is showing me that there's still inflammation here. What can we do with your treatment plan to get ahead of this? Because we want to stop any further damage that this inflammation is going to cause you. So immunosuppression is one bucket there. There's a lot of research looking at hormone changes and how this is protective or not protective for multiple sclerosis. And what you might be familiar with is in the period of pregnancy, it's actually very uncommon for women with multiple sclerosis who are pregnant to have relapses during their pregnancy. There is a protective effect of estrogen and progesterone during that state. In the postpartum period, or immediately after, is when there's actually a high risk of relapse. And so we know that some fluctuations of the sex hormones do play a role here. And there's a lot of research going on to better understand how do we optimize postmenopausal MS? Is there something that we can do with estrogen to protect multiple sclerosis patients as we age in the postmenopausal period from this chronic inflammatory state? Because it's actually less common as we get older to have these very stop you in your track relapse events. It's more common to have these chronic gradual changes. So what can we do to get ahead of these chronic gradual changes while we're living that experience, while it's happening, assuming we've already done our part with immunosuppression early on. Is there more that we can do? And there's a lot of research looking into this for both men and women. Low testosterone is also associated with increased multiple sclerosis risk, as well as heightened neurodegenerative factors. So brain atrophy tends to happen more in men with MS that have low testosterone. So there's a lot of studying looking into this as well. Then lastly, there's so much in the epigenetic world that there's a lot of research pouring into this and trying to better understand how can we modify our epigenetic risks that are going on in the background while we're taking care of the environmental, the hormone fluctuations, the autoimmune syndrome that we have here. What can be done about our epigenetics? And that certainly is a cutting edge field that still is growing for us to better understand. So you heard already that as we get older, it's less common to have these clinical relapses where all of a sudden one day there's a acute onset of a new change in your function. Similarly, it's less common to get a new white matter lesion on your MRI when you're older with multiple sclerosis. And I'm talking about 60 years old plus. So when you're over the age of 60, having new white matter lesions for someone who's been controlled on a therapy is not so common. But what we can appreciate is changes in brain structure, which you might not notice from one scan to the next year's, but you might notice if you look at your scan when you're 20 and you compare it to your scan when you're 60. So it's these slower changes that we need to work better on getting ahead of. This happens not just in the brain, but also the spinal cord, which is why sometimes if you've had an old spinal cord attack, as you're aging, the symptoms from that spinal cord attack may not have been all that prominent when you were in your 20s when it first happened and you recovered. But when you're 70, you might feel a bit more spasticity or stiffness because of an old lesion. Again, any new symptom should, of course, prompt a new evaluation, new imaging to really be sure that's the case. But we want to try to prevent this. We want to get ahead of this so this doesn't happen. And similarly, we find correlation with certain changes on different structures of the MRI with the cognitive and mood changes that you heard me introduce earlier today. So what can we do to combat progression? So early high efficacy treatment with a disease modifying therapy, extremely important, but your day-to-day is also really important. So maintaining your best self, maintaining a healthy body mass index, which means a healthy weight, is associated with a decreased risk of MS-related disability and disease activity. Managing your general health with your primary care provider is so important. We certainly see that patients who have multiple sclerosis and untreated hypertension or coronary artery disease seem to also have higher MS-related disease activity. So really managing these cardiovascular comorbidities is also essential for getting ahead of your MS. And lastly, diet. So not just in order to impact a healthy weight, but there's a lot of research looking at the microbiome. The microbiome is a term that describes your gut flora. So we have different bacteria that colonize our gut. And some bacteria are pro-inflammatory and some are anti-inflammatory. And there's a lot of research pouring into this to see how can we modify the gut microbiome in such a way to say that there's more anti-inflammatory bacteria there that we need than pro. How can we be sure that we can really be sure the gut microenvironment is not also contributing to inflammation? So certain diets seem to help with that as well. Although there are many different types of diets that you might read about, let's say if you go to the nationalmssociety.org, there's a great page that talks about different multiple sclerosis recommended diets. But really the one that's tried and true is the Mediterranean diet. This has been studied in numerous different research settings and has been found to be associated with better cognition in those with MS who are adherent to a Mediterranean diet. Of course, food that aren't considered Mediterranean diet food groups are permissible, but in moderation. And you really do want to make the majority of your food intake modeled after this Mediterranean diet of chicken, fish, lean meats, fruits, nudgies, vegetables. You want to eat healthy because this helps make sure that our microbiome in our gut is more of these healthy anti-inflammatory flora. And it also seems to have a really positive impact on just brain health and memory, even for patients without multiple sclerosis. So important. And to bring us back to a concept introduced earlier, vitamin D deficiency. It's associated with increased risk of multiple sclerosis onset, but also more frequent relapses and later disability. So even once the diagnosis of MS is made, it's so important to stay active in that realm and to recognize if your vitamin D is low, to be ahead of it, to be appropriately repleted, to take dietary supplementation, and certainly review what dose is recommended by your provider with you specifically, as everyone's needs are slightly different. But the general practice is somewhere between 2,000 to 5,000 units of vitamin D3 a day are going to be what's helpful to keep your vitamin D in a normal range level. With healthy diet, you can imagine exercise also plays in, and it certainly does. It's good for your brain health with or without multiple sclerosis. But importantly, how it relates to multiple sclerosis is it helps mitigate these more chronic associated symptoms. So pelvic floor physical therapy can help re-strengthen your pelvic floor muscles if there's any musculoskeletal component that contributes to urinary incontinence. Exercising gives you energy, gives you positive mood endorphins, and just helps with your day-to-day, just your bandwidth to really get through your day. It also helps with memory. So there have been many studies to show that those that are exercising regularly have less likelihood of developing things like Alzheimer's later. So you want to do everything you can to not only treat your MS, but to help protect yourself from developing other conditions as well that could also have impact on your functionality, on your brain health. And it doesn't have to be rigorous. You don't have to be training for the marathon, but routine exercise, something that's regular, is helpful, even if it's 15 to 20 minutes a day of some yoga, low intensity. Of course, cardio is probably the most effective, but any exercise that can be tolerated is better than not exercising. So really consistency with whatever level of exercise you are able to physically accommodate as well as logistically accommodate really just goes for miles. And when you think about future implications on better outcomes with cognition, with physical self. And other wellness things that are important to touch upon, we talked about diet, we talked about exercise, sleep, something in our society that's really not really talked about enough, but ensuring adequate sleep is so critical for your health in general to help lessen the likelihood of developing things like cardiovascular problems, but also really important for keeping your cognition sharp. So there are a lot of studies that show that poor sleep early in life will equal a higher likelihood of dementia later. So you have to take care of yourself every day, right? It's all an investment for your future self. Abstaining from smoking, whether it's primary or secondary exposure, is really important. And lastly, alcohol in moderation. You'll never hear neurologists say that you should drink. And it's because we know that alcohol actually can take away your B12, which is important for nerve health. It also can damage many organs and also play a role in dementia risk later in life. So moderation, of course, is appropriate, but trying to minimize that as best as possible and really stick to healthy dietary intake is the way to go. Drinking alcohol, not sleeping well, these are things that actually can cause that reemergence. They can lower the water level, so you actually feel a bit more symptomatic in these settings. So really other important reasons on a day-to-day basis why it's important to just try to feel your best. It's by excluding these things as possible contributors. We've already touched a bit on why heart health is important for MS. Bone density is also important. If you think about how a relapse might be treated, oftentimes we give high-dose steroids. Sometimes some of our MS treatments are actually preceded by high-dose steroids as part of a pre-medication package. With the steroid exposure through time, we're actually increasing the risk of things like osteopenia and osteoporosis. So certainly important to not only take your vitamin D, but work on the impact exercise if you can, and talk to your primary care provider about monitoring you for your bone density to be sure that you can maintain your strongest self. And of course, thinking about what your medication list entails. It's very easy for someone to have prescriptions from multiple subspecialists, and perhaps those subspecialists aren't aware of all the medications you take. And so really at every visit, going over your medication list is so important, so we can be sure that there are not medications that are going to interfere in such a way to decrease the effectiveness of another one that would benefit you, as well as to ensure that there's no cross reaction that would give you a side effect or take away from your energy storage. So we really want to just take care of you as the full patient, not only think about, you as brain, spine, and eye nerves with the myelin areas. We want to think about you as a person, as a whole, to be able to say that you're getting the best care. So that way, living with multiple sclerosis is living well. The most important piece to really think about in terms of prescriptions, it takes us back to the disease modifying therapies, the treatments that are FDA approved for treating your multiple sclerosis. You've heard me really speak highly of these high efficacy treatments. As we age, there comes to be a time where we have to continue to reassess, is the medication you've been on the right medication for you? So we know for secondary progressive multiple sclerosis, we really only have two options that are really shown to be in trials effective. Hopefully with time, there will be more that will be studied to be effective, but right now that restricts us to ocrelizumab and siponimod. These are ones that we're going to use if we're concerned that you're entering a progressive phase of multiple sclerosis, because these have been shown to halt progression. In many cases, you'll already be on these for the relapsing remitting phase, which will work twofold. It'll treat the relapsing remitting components of multiple sclerosis, as well as slow the chronic smoldering inflammatory piece. There's a new biomarker that you might hear about or you might bring up to your provider called neurofilament light chain. What we're doing is, as a field, trying to understand, are there any tests that could guide us as to how someone might do in the future? And neurofilament light chain is by no means specific for multiple sclerosis, but there have been a few studies that show that an elevation of this level through time might be associated with the more chronic active inflammation and disease progression. So this is something that is variably practiced. I don't always order it for all of my patients as we're still learning how to use this, but sometimes it can be helpful when you're trying to better understand, whether someone continuing on medication, the benefit of that continues to outweigh the risks. What I mean by that is a lot of these immunosuppressives have risks of infection. And so you really have to balance, are we still in a point of your MS where it makes sense to be on something so strong? As we get older, there is this phenomenon of our immune system naturally weakening. So maybe ocrelizumab in your 20s, you never got sick any more than anyone else, but ocrelizumab in your 70s, your 80s, maybe now you're getting a lot of urinary tract infections. And if that becomes to a point where it's so frequent or so serious that you're actually at more harm than good, we have to do whatever we can to be sure we can still manage your multiple sclerosis, but more importantly, being sure that you're tolerating the therapy provided to you. So this requires an individualized conversation through time. Again, sometimes this neurofilament light chain lab could be helpful for thinking about these discussions, because there's not a defined one size fits all age. It would be nice if we're able to say that, but because multiple sclerosis can also be late onset and develop after someone's 60, I'm not sure we'll ever be able to say, for this age, you can now pull back on this type of treatment, right? So it's a very individual conversation that needs to be had to be able to say that you're clinically sufficiently stable enough, but now the risks of potential side effects and infections are too high that we really need to think about what we're doing and how we're treating MS. So this is probably the most important piece to think about when we're thinking about the topic of MS as we age. Here are just some things that are going to go through the mind of the provider. With long-term immunosuppression, we think about you actually could lose some of your protective antibodies, your IgGs. And in some situations, we're able to actually give IVIG, a synthetic version of the IgG, back to patients with MS. If it is so low because of treatment and you're getting clinically ill, this is often a practice that's done. It's chronic use of certain medications like these S1P inhibitors now no longer appropriate because we're struggling with management of high blood pressure. Your health through life will change and will change the way that certain medications may or may not be appropriate for you. Will you have developed diabetes? And if so, again, the S1P inhibitors are a little bit more carefully monitored because there is a risk of an impact on your eye. So there are things that we have to continue and surveil with each different medication. But with each person, as we grow older and our health changes, we have to think about what else is going on in the background, and does this medication remain the right one for me, which is why it is so important to continue to check in with your MS provider. Even if you've been stable on treatment for years and years, having at least an annual visit is good, because sometimes things in your general medical health will come about and will paint the way that we're able to best care for you and your MS. So I'll end with some final summary points. I think I like to always share this whenever I speak about multiple sclerosis, is just sharing how you can most be empowered to really direct your own care. So your doctor will think about all these things in the background, and it's really important to kind of bring to the table your values, your worries, things that are affecting you on a day-to-day basis, and just being sure that you have a really strong relationship with your neurologist and the rest of the care team is so critical, because this is essentially a primary care type relationship. It's going to be longitudinal and through time. So it's important that you're comfortable asking questions, voicing your opinions, and really sharing any concerns you might have about any treatment plans that have been shared with you. It's really challenging, but also important through time to become familiar with how MS affects you. And so if you feel profoundly fatigued and it's not matching your expenditure of energy in a day's work, bring this up with your primary care provider. We know things like fatigue are secondary from MS. There are times when it's not the MS driving the fatigue, but it's important to really evaluate that so that way it can be appropriately managed. It's important to really use the referrals and the other collaborative team members that are out there. So if your MS provider feels that there is weakness on your exam that you also notice that's impacting your day-to-day, as best as you're able to logistically from a time and financial perspective, make time to really incorporate the suggested referrals to physical therapy as an example, and really ask questions. Get involved if you feel comfortable. There are so many great chapters through the National MS Society that can continue to provide education seminars like this and just help you be an informed person to really live your best life and your best self, because you'll know what and how to ask and to notice and recognize. So in summary, MS affects everyone differently. There are a list of common symptoms that can happen, but there are things that are a little bit less obvious at the forefront that with time become more apparent. So always important to kind of speak and share what you're experiencing on a daily basis so your provider can adjust your care plan accordingly. And with that, we want to treat multiple sclerosis early, be as strong as we can, because again, all of our medications are truly preventative. We want to be proactive. We don't want to get behind the inflammation, and then you're having more attacks, and it's really hard to repair from that. There are more than just immunosuppressants that are a part of this puzzle. Lifestyle considerations like exercise, healthy eating, vitamin D deficiency, smoking cessation. These are all things on a day-to-day basis that can be done from a patient's side, in addition to taking the prescribed disease-modifying therapy to really help you be your best self and to keep multiple sclerosis in the background and equal better outcomes later down the line. And the medication and treatment care plan that works for you today might not be the same in the future. And so ongoing reassessment of what your needs are, what you're able to tolerate from a side effect profile, what your worries might be, will all be important to continue to share with your provider along your MS journey to be sure that we're always treating your multiple sclerosis in the best way. And so we can continue to age without any significant impacts by being proactive and continuing to modify our course as needed. So with that, I'll thank you for your attention and happy to answer any questions there might be.
Thank you so much, Dr. Manzano. We do have about a minute left, so if anyone has any questions, feel free to enter them in the chat. We have a question regarding the diagnosis of MS. Is it worse if one's diagnosed with MS earlier or later in life?
It's a good question. So I would say it's always better if we can try to diagnose multiple sclerosis earlier in its course. So the age doesn't necessarily give us, a better or worse scenario, because multiple sclerosis can come about in your 20s. It can also come about in your 60s. When it does come about later in life, it tends to more commonly be the progressive subtype, which, as you heard, we have maybe 2 really good treatment options. So your arsenal of treatments are a little different, but whenever we catch it, we just want to catch it early when it develops. So it's not necessarily how old you are, but rather it's more about the time that you've had the condition for that's important.
Thank you. And we have a question of whether elevated serum ferritin can be associated with MS.
We haven't really found a direct correlation there clinically. Sometimes, ferritin, the reason that you might be asking is this can be elevated in conditions of like chronic inflammation at baseline. So we more often see that with systemic, like non-neurologic inflammation, things that are rheumatologic type patterns, or they could be reflective of just issues with iron storage and processing, but there's not a very direct correlation there with MS disease activity.
Thank you. Aside from the National MS Society, are there any online resources you recommend for someone to learn more about MS as well as managing MS as we age?
Yeah, I think honestly, National MS Society is just probably the most tried and true website that I'm familiar with, and it's just a great nonprofit organization, and I always direct my patients to that. There are some types of demyelinating conditions that aren't quite MS, but essentially cousins of MS, or other sister foundations like the Samara Foundation, for example, is another one, but that tends to be more focused for people with a syndrome called NMO or MOGAD. So really, multiple sclerosis patients are probably going to find best resources on the National MS Society.
Thank you. So we are about time, but before we end today's session, do you have any final thoughts you'd like to share with the audience, Dr. Manzano?
I think just thank you for having me, and thank you all for listening. And I think the only final thought I would share is just that expression of feeling empowered to share what you're experiencing in your day-to-day, because you saw the many different options and things kind of in our back pockets as providers that we can offer you. So if there's anything that doesn't seem like it's going well, or you're worried could be related to your MS, it's always good to just bring that up and let that be explored.
Absolutely. Thank you so much. And for everyone who joined us, thank you so much. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you, everyone.
Thank you.
Take care.
Bye.